Hello everyone and welcome back to my channel. So today's topic is vasculitis, and you know how important this topic is for Neet PG. And there are so many questions, so many short differences between each of these entities, and I'm going to take you through this topic from Robbins and also some additional points from here and there. So let's get started with today's topic. Now, a vasculitis is a general term for vessel wall inflammation. This is basically the definition. So, I'll just take you through the classification of vasculitis. So, it has a very simple outline. A vasculitis may be of a large vessel type, medium vessel, and a small vessel. Large vessel may you have a giant cell arteritis and Takayasu arteritis, and you have to know the differences between them. Medial vessel may you have immune complex mediated, under which you have the pan or polyarteritis nodosa, and anti-endothelial cell antibody may you have the Kawasaki disease. Small vessel may you have this immune complex mediated or posi-immune, which is not immune complex mediated but it is ANCA associated. So immune complex mediated may you have the SLE, henoxolin purpura, cryoglobulin vasculitis, and good pasture syndrome. In post-immune, we have the microscopic polyangiitis and granulomatosis with polyangiitis, which is the Wegener's and the Church-Strauss. So this, and over here this and this and this. So all these entities you have to know the differentiating points and the most important words which will clinch your diagnosis, and also the remaining statements, because in the exam you get questions like which of the following statement is correct or incorrect. So you need to know the details also. So here first I would like to tell you that there are two kinds of ANCA, which is P ANCA and C ANCA. P means perinuclear and C means cytoplasmic. P ANCA is basically antibodies against MPO or myeloperoxidase, and C ANCA is basically anti PR3 or proteinase 3. Now this is easy to remember that because it is P ANCA, so MPO. Okay, this is basically the short mnemonic. So P ANCA MPO, this is how you remember. And don't see this word. Okay, yahan par it starts with P, but don't kind of get confused here. P means MPO. Okay, proteinase is C ANCA, so don't get confused. You also have a P over here, but then what I mean to say is take this P into consideration. So P ANCA is positive in microscopic polyangiitis and Church-Strauss syndrome, very important. And C ANCA in Wegener's granulomatosis. Now these are basically your last minute revision topic. So these words or these points are volatile, but then you have to read it just before your exam so that you don't forget. Now ANCA is also increased in ulcerative colitis, SLE, and PSC or primary sclerosing cholangitis. So basically this was the diagram I was talking about, and this is where from I have mentioned these important points that large vessel may you have this granulomatous disease, which is giant cell and Takayasu. So which are granulomatous means which have granuloma, you have to know them. Okay, so large vessel may you have granulomatous means both of these entities are granulomatous. Medium vessel may you have immune complex mediated, which is a polyarteritis nodosa, and anti-endothelial cell antibody, which is the Kawasaki disease. Now a small vessel may I've already mentioned, you have this microscopic polyangiitis. This is vasculitis without asthma or granuloma. So microscopic polyangiitis may you do not have asthma, you do not have granuloma, but granulomatosis with polyangiitis, which is basically your Wegener's granulomatosis, because this is what I mentioned over here, that granulomatosis with polyangiitis is the Wegener's granulomatosis, and this is where you have association of granuloma but there is no asthma. But in case of Church-Strauss syndrome, you have asthma and granuloma, right? So if I can just mention you that if you talk about vasculitis and asthma, I'll just write this down for you, because so if we talk about asthma and granuloma, let's try this out. So in microscopic polyangiitis, you do not have asthma, you do not have granuloma. In case of granulomatosis with polyangiitis, this is basically your Wegener's. Okay, here you have no asthma but you have granuloma. And if you talk about the Church-Strauss syndrome, you have granuloma and you also have asthma, all of this. So this is basically the small vessel vasculitis. And small vessel vasculitis may you either have posi-immune, means this is associated with ANCA. So all these three are associated with ANCA, and this is posi-immune, you don't have immune complex deposition. And small vessel vasculitis can also be immune complex mediated, under which you have all these four entities. So please understand that a small vessel can be post-immune and it can also be immune complex mediated. Okay. Now, the pathogenic mechanisms of vasculitis are immune mediated inflammation and direct invasion of the vascular walls by the infectious pathogens. So, what are the non infectious vasculitis? Number one, immune complex deposition, ANCA mediated anti endothelial cell antibody, and autoreactive T cells. Now, coming to this individual points, okay, giant cell arteritis is happening more than 50 years and Takayasu is happening less than 50 years. Okay, so please see, these are the points, clinching points. Number one, Takayasu is less than 50 years and giant cell is more than 50 years. So whenever you read these entities, please compare and read, otherwise you will not remember, because these are volatile points. Okay, so let's talk about this now. Giant cell or temporal arteritis may, this is a chronic, classically granulomatous inflammation. I've already mentioned that large vessels are, both of them are granulomatous. Okay, so let's just write this point down over here, that large vessel vasculitis जो भी है उनमें both of them are granulomatous. Okay, so yes, there is a granulomatous inflammation of the large to small sized arteries that principally affects arteries in the head. Very important, arteries in the head. It is the most common in the elderly adult more than 50 years. The temporal arteries are not particularly vulnerable, but why we say the name temporal arteritis? Because it is superficial, number one, and because these are the most readily biopsied to make the diagnosis, and that is why the name is temporal arteritis. Okay, ऐसा नहीं है कि this has got a more predilection, इसीलिए नहीं, इसीलिए because it is more readily biopsy to make the diagnosis. That's why we say temporal arteritis. Now, vertebral and ophthalmic arteries as well as the aorta, known as the giant cell aortitis, is involved here. Now, because the ophthalmic artery is involved, there is sudden and permanent blindness. So these persons have to be treated very promptly, otherwise there's going to be blindness. Okay, now, a giant cell arteritis happen because of a T cell mediated immune response. The pro-inflammatory cytokines and the anti-EC antibodies are also contributing and has excellent response to steroids. Now, very important, the arterial segments develop intimal thickening that reduces the luminal diameter. Okay, there is thickening of the intima and there is a medial granulomatous inflammation centered on the internal elastic membrane with elastic laminar fragmentation. So please be very careful, all these points are super important. There is medial granulomatous inflammation, means in the tunica media you have granulomatous inflammation, you have elastic lamina fragmentation, and you have intimal thickening. There is infiltration of the T cells, you have the CD4 cells which is predominant, and inflammatory lesions are only focally distributed along the vessels and segments. So there is segmental distribution. This is again a very important point. You know, the entire of the artery is not involved. The inflammatory lesions are focally distributed along the vessels and segments of some normal artery may be preserved. So please also keep this point in mind, that there may be, that there is basically a segmental involvement. Okay, now, if we talk about the healing stage, it is marked by medial attenuation and scarring with intimal thickening, fragmentation of greater than 30% of the circumference of the internal elastic lamina, and adventitial fibrosis. Now, what is the most specific symptom? Yes, we know that ocular symptoms are there. There is basically headache or facial pain, and you have ocular symptoms that abruptly appear in 50% of the patients. This range from diplopia to complete loss of vision, and adequate biopsy requires at least 1 centimeter. Now, why? Because I've just mentioned that this is having a segmental involvement, means only some portion of the artery segment is involved, and therefore you need to have at least 1 centimeter to identify this lesion, because if you take less than this then you may not get the diagnosis. So because of the segmental involvement, at least 1 centimeter, very very important question, at least 1 centimeter, and that's why this point becomes important, that it has got a segmental involvement. Corticosteroids or anti-TNF therapies are typically effective. And please don't forget this point, that the most specific symptom is jaw claudication. Okay, this is a very very important MCQ point. Now coming to Takayasu arteritis, again granulomatous of medium to large size arteries. characterized principally by ocular disturbances and marked weakening of the pulses in the upper extremities. So there is a weakening of the pulse in the upper extremities, but in the lower extremities the pulse is normal. This is known as aortic arch syndrome or pulseless disease, because the upper part of the body is having weakened or feeble pulse. Okay. There is also ocular disturbances. There is transmural fibrous thickening of the aorta, particularly the aortic arch and the great vessels, with severe luminal narrowing of the major branch vessels. Takayasu arteritis classically involves the aortic arch, and therefore it is called as the aortic arch syndrome, right? Now, pulmonary involvement is present in half of the cases. Coronary and renal arteries may be similarly affected. There is irregular thickening of the vessel wall with intimal hyperplasia when the aortic arch is involved, and there is a marked narrowing and obliteration of the lumen. Such narrowing explains the weakness of the peripheral pulses. So because of this marked narrowing and obliteration, basically there is weakening of the peripheral pulses. Now histologically you're going to find that there is adventitial mononuclear infiltrates with perivascular cuffing of the vasa vasorum to intense the mononuclear inflammation in the media. Granulomatous inflammation replaced with giant cells and patchy medial necrosis. So the important points I mentioned: intimal thickening, the media is attenuated. You must remember these points. I mentioned this from here, but these are basically the MCQ points. So intimal thickening occurs, the media is attenuated, there is mononuclear inflammation and giant cells. Okay, and the subclavian vessels are involved here, the aortic arch is involved here, the other arteries are also involved here. Okay. नाउ टाकायोसो आर्टेराइटिस में कुछ पॉइंट्स मैं फिर से बताना चाहती हूँ. दैट इज द सबक्लेवियन आर्टरी इज द मोस्ट कॉमन, द coronary artery is the least common. Okay, pulse may it is absent in the upper extremities but present in the lower extremities, and microscopy may you have granulomatous inflammation with giant cell. Okay, now coming to the polyarteritis nodosa, this is basically small to medium sized muscular arteritis typically affecting the renal and visceral vessels but spares the pulmonary circulation. Very important point, that there is no involvement of the pulmonary circulation, it is associated with ANCA. These are the very important points. Now it is associated with segmental transmural necrotizing inflammation of the small to medium sized arteries, often with superimposed aneurysms or thrombosis. Kidney, heart, liver and GIT vessels are involved in decreasing order. So the most involved is kidney, then heart, then liver, then GIT. So this is decreasing order of frequency. Lesions only involve part of the vessel, which means these also have got segmental distribution. Okay. In the acute phase, there is a transmural inflammation accompanied by fibrinoid necrosis and luminal thrombosis. Okay. So these points are important. I'm just going to highlight this for you, that there is going to be segmental, very important point, transmural, important point, and necrotizing. Okay, and it also had got superimposed aneurysms or thrombosis, and this point, it spares the pulmonary circulation and it is associated with ANCA. And another most important point is that it has got association with the chronic hepatitis B, and therefore you have deposition of this particular complex. So PAN is having association with the chronic hepatitis B. And now if I just show you this, just for your revision, that it is affecting the medial vessel. The renal artery is the most common vessel affected, and therefore you have renal failure, which is the most common cause of death. There is no glomerulonephritis. Very important point. Yes, the renal artery is involved, but there is no glomerulonephritis. Okay, now pulmonary vessel is never affected. AG is positive, as I mentioned. This is type 3, means immune complex mediated. It may be associated with mononeuritis complex, again a very important point. And all stages of inflammation are simultaneously seen in a single vessel. Again a very important point, that all stages of inflammation are seen simultaneously in a single vessel. So basically you have to by heart these points, because in the exam you will be getting questions from these points only. They will be framing some sentences or the other from these points, and you have to say which is correct, which is wrong, and things like that. So every one of them is important. So you can see that this is basically the segmental fibrinoid necrosis, right, which you can see in this image. Now, a Kawasaki disease, yes, this is acute febrile self-limiting illness of infancy and childhood associated with a medium-sized vessel. There is involvement of the coronary arteries, and therefore this can result in aneurysms causing rupture and thrombosis, and ultimately resulting in myocardial infarction. This resembles PAN. This typically presents with conjunctival and oral erythema and blistering, edema of the hands and the feet, erythema of the palms and the soles, a desquamative rash, and cervical lymph node enlargement, and hence it is also named as mucocutaneous lymph node syndrome. It has got a lot of cardiovascular complications like asymptomatic coronary arteritis, coronary artery ectasia, giant coronary artery aneurysms, rupture, thrombosis, MI, sudden death, etc. So I'll just go through this point, which is the Kawasaki disease. Now, इसमें क्या criteria है? As you can see that fever for more than 5 days and plus any one of this following, out of which we have conjunctivitis, lymphadenopathy more than 1.5 centimeter, rash which is polymorphous, change in the lips or mucosa like the strawberry tongue, and the change in the extremities like the erythema of the palms and the soles. So this is known as mucocutaneous lymph node syndromes, happen in the child less than 5 years. Coronary artery is the most common involved, leading to myocardial infarction. Diagnostic criteria may you have fever and any 4 of the following, out of which you have conjunctivitis, a non-purulent rash, edema, unilateral cervical lymphadenopathy, and mucosal involvement known as the strawberry tongue. Now, granulomatous vasculitis is present in these conditions. This is an important question. I've mentioned them at one place. Burgess disease, temporal arteritis, Church-Strauss, Takayasu, and vaginous granulomatosis. So now coming back to this microscopic polyangiitis, is a necrotizing vasculitis that generally affects the capillaries as well as small arterioles and venules. Unlike PAN, all lesions of this tend to be of the same age in the given patient, and suggesting a single episode of antibody or immune complex deposition is also known as the leukocytoclastic vasculitis. The skin, mucous membrane, lungs, brain, etc. all can be involved. Most cases are associated with MPO ANCA. There is segmental fibrinoid necrosis, typically the post-capillary venules, and only infiltrating and fragmenting neutrophils are seen, giving rise to leukocytoclastic vasculitis, and this is basically post-immune. Okay, these points are also very, very important. So this is coming under the microscopic polyangiitis, right? So if I just come back to this is basically affecting the small vessel. It's leukocytoclastic vasculitis. It has got necrotizing glomerulonephritis. So this basically differences from the PAN. Here there were no glomerulonephritis, but here you have this necrotizing GN, and this is associated with P and K, and pulmonary vessels here may be affected, but here it was never affected. Okay, so now this vaginous granulomatosis, this is having acute necrotizing granuloma of the upper and lower respiratory tract. Necrotizing or granulomatous vasculitis more prominent in the lungs in the upper airways. They can also be focal necrotizing, often presenting glomerulonephritis. Very important point. Okay. So basically here what you have the C ANCA positive and you have the lung and the kidney affected. There is granulomas with geographic patterns of central necrosis and accompanying vasculitis. Very important histological feature. Now coming to Church-Strauss syndrome, this is allergic granulomatosis and angiitis, small vessel necrotizing vasculitis associated with asthma, allergic rhinitis, lung infiltrates, peripheral eosinophilia, extravascular necrotizing granuloma, and a striking eosinophilic infiltration of the vessels and tissues. There is cutaneous involvement with palpable purpura, GIT, and renal disease, primarily this focal segmental glomerulosclerosis. Now, a thromboangiitis obliterans or Burgess disease is basically characterized by segmental thrombosing, acute and chronic inflammation of the medium and small size arteries, especially the tibia and radial arteries, that often leads to vascular insufficiency, typically of the extremities. Microabscesses are found in case of thromboangiitis obliterans. This is again an important point. So I hope you learned something from me today. If you like my content and my effort, then please like, comment, share, and subscribe to my channel and support me. I will meet you very soon in my next episode. Till then, take care, keep studying, and thank you for watching.